Good evening. Thank you for joining us for this webinar tonight. This webinar is a collaboration between the Singapore Nutrition and Dietetic Association and FrieslandCampina Institute. My name is Shalyn Yamanaka, and I am a dietitian in private practice here in Singapore and on the CE committee for the SNDA. Food allergies continue to rise in prevalence around the world, and that includes here in Southeast Asia. Unlike many conditions, allergies have lots of nuances, and the research has dramatically changed over the last 10 to 15 years. Tonight, we'll learn what current research is indicating and the recommendations for our youngest patients. As we are speaking about babies tonight, we would like to remind everyone that breastfeeding is the best nutrition for healthy growth and development. Recommendations are for exclusive breastfeeding until 6 months, when complementary feeding should be added and continued to 2 years and beyond. Mothers should consult their doctors before using any milk substitutes, and social and financial implications should also be considered. Now, without further ado, I would like to introduce Adjunct Associate Professor Ann Goh. She is the head of the Pediatric Allergy Service and Senior Consultant of the Respiratory Medicine Service at the Department of Pediatrics at KK Women and Children's Hospital in Singapore. She is also a past president of the Singapore Pediatric Society and is an adjunct associate professor at Duke NUS Graduate Medical School and the Lee Kong Chian School of Medicine. Now, allergies have a lot of information out there as the field continues to evolve and change. And with regards to nutritional interventions, there is a lot of information, and sometimes it's very confusing as things change rapidly. Tonight, Professor Goh will be talking about some of the applications regarding nutrition interventions and help bring some clarity to this area for us. And I would like to please join me in welcoming Adjunct Associate Professor Ann Goh.
Thank you, Shalyn, for that very kind introduction. Okay. Can you share the slide for me? Since I can't seem to be able to share it. Okay, sure, it's fine. I found that. Okay, can you hear me? Yeah, thank you. Thank you, Shalyn, again for that very kind introduction. And my role today will be to talk about nutritional interventions in food allergy. And you know that food allergy primarily affects young infants and children. And many attempts have been made in the past to see if prevention was possible, because obviously a food allergy in a child has a great impact on the family as well as the child, and it is a very stressful situation. As far back as as far back as the year 2000, the American Academy of Pediatrics had made some recommendations, and basically they had recommended that mothers breastfeed for as long as possible, at least up to 6 months to a year. And in high-risk infants, mothers were recommended to eliminate peanuts and tree nuts from their diet, and whilst breastfeeding, to attempt to eliminate other allergenic foods such as milk, eggs, and fish. And they also recommended that allergenic foods be delayed. However, we do know that these attempts were not very successful. For in 2008, you see this publication from the European Molecular Biology Organization, which basically suggests that food allergies are on the rise. And you've actually heard our chairperson mention too that food allergies are rising around the world. And this was very nicely demonstrated in Australia, where they've shown that food allergy incidence has progressively risen over the years, from as early as 1990 over the next 14 years. You see this steady rise in food allergy. And this is not just particular to the developed countries. You are seeing this happening even in the developing countries as well as in Asia. I'm going to talk a little bit about the association of eczema with food allergy, because there is a very important association. Danish allergy research cohort actually demonstrated very nicely that eczema precedes the development of food allergy. You will find that many parents, when the child develops eczema, particularly the young infant, the first 3 months of life, they're always looking for a food allergy that may be causing the child's eczema. But really remember that eczema comes first. So eczema is primarily still a skin dysfunction disease. It's a skin disease which causes a disruption of the skin barrier. And this predisposes the child to the food allergy and not the reverse. Okay, so you can see very nicely from as early as 3 months, many of these children already have atopic dermatitis. And it's only much later that you see the presence of food allergy occurring. And what they've demonstrated is that these infants with eczema were more likely to be sensitized to food allergens, and in particular, egg, milk, and peanuts. Okay, and you find that it is definitely a lot more common in children with eczema compared to those without eczema. And what they demonstrated very nicely too, that besides being sensitized, these infants with eczema were also at increased risk of developing egg, milk, and peanut allergy. So what is this association between eczema and the development of food allergy? And this was very nicely demonstrated in this dual allergen hypothesis that was put forward by Professor Gideon Lack. The skin basically was meant to be an intact barrier to prevent the exposure of food allergens. But when the child has eczema, there's disruption of the skin barrier, and therefore food allergens are now being exposed to the skin, and this causes Th2 memory induction, which predisposes this child to the development of allergy subsequently on exposure to this particular food. The way that food allergens are meant to be introduced into the child's body is through oral ingestion, and the gut has been designed such that when it's exposed to food allergens in the gut, it induces a Th1 memory cell and T regulatory memory cells to induce tolerance. Therefore, there is a gradient of risk for the development of food allergy. And the risk is extremely small in the general population, where there's very little evidence of history of atopy in the family or the child having eczema. And that risk is less than 1%. Okay, whereas if there is a family history and other histories of food allergy, and in particular, if the child has severe eczema from very early on in infancy, within the first 3 months of life, then they are at the greatest risk of developing food allergy. So that's the group that we really need to manage. And so to summarize this bit of it, it's infants with severe eczema that are at the highest risk of developing food allergy. So are there nutritional interventions that can be used to prevent food allergy, particularly in this high-risk group? And I've listed some here, such as the introduction of complementary diets, especially the timing of allergenic foods, breastfeeding, the use of hydrolyzed formulas, pro, pre, and symbiotic use, as well as the use of long-chain polyunsaturated fatty acids. And I'm going to touch a little bit on vitamin D as well. I'm going to touch first on the timing of introduction of allergenic complementary foods, because this is where the biggest change has probably occurred, and probably that's where the main benefit has been found. And I'm going to touch on peanut first. And peanut actually came about when there was this observation made that children of Jewish origin who were born in Israel and those born in UK or United Kingdoms had very different incidences of peanut allergy. And the main difference they found was the fact that peanut was fed very early in life to children in Israel, as early as within the first year of life, 70% of whom were consuming peanuts by 9 months of age, compared to those who were brought up in the UK, who very religiously followed guidelines which say delay introduction of peanut. And only 10% of Jewish children in the UK were given peanuts by the age of 9 months. However, there was a marked difference in the incidence or prevalence of peanut allergy. As you can see, in UK, there was a 6-time increased risk of the children developing peanut allergy versus those in Israel. Therefore, this gave rise to the concept that maybe early introduction of peanut may be protective. And that led to this landmark study that probably all of you may have heard about, the LEAP study, where they actually looked at high-risk infants, infants with eczema and with or without egg allergy. And they said these were the group at risk. And these children between 4 to 11 months were then randomized to either avoid consumption of peanut or to have peanut from as early as 4 to 11 months of age all the way till 5 years of age. Okay, so these children were then divided into an avoidance group and a consumption group, right? And you can see very clearly from this results that at 5 years of age or 60 months of age, there was a higher incidence of peanut allergy in the group that avoided peanut as compared to the group that consumed peanut. Okay, again, lending very nicely to the observation that was published earlier that early consumption of peanut was probably protective. And this was found even when they stratified these children into those who were already sensitized compared to those who were not sensitized. And you can see that there were children who were positive on skin prick test to peanut, as well as a positive IgE level that if they consume peanut, they still had a lower risk of developing peanut allergy versus those who avoided. So whether you were sensitized or not sensitized, consumption of peanut was still protective. And this was again verified by the EAT study, where they introduced the 7 allergenic foods as early as 3 months of age in an attempt to see whether early consumption of these allergenic foods would be protective in the same way that early consumption of peanut would be. When they looked at peanut specifically, again, they showed that there was protection against development of peanut allergy if they consumed it early. The other major food that was found to have an impact was the early consumption of egg. And this petite study came from Japan, where they randomized Japanese infants again with eczema at 4 to 5 months of age into a group which was given egg protein versus those who were not. And it was a graded amount of egg protein, so they gave a smaller amount in the very younger infants, and they increased the amount when the children or these infants reached 9 months of age. And they found that the infants who were introduced to egg protein had a lower risk of development of egg allergy. And again, in the EAT study, they had the similar findings that when the children were introduced to egg early in infants, as they were weaned, they also had a reduced incidence of egg allergy. So this is a systematic review and meta-analysis that was published in JAMA, and basically what they also found that for egg and for peanut, there was a reduction in the development of peanut and egg allergy if these foods were introduced between 4 to 11 months of age. However, they did not find this protection in association with milk. So the second point to take home, therefore, is that introduction of peanut-containing foods as well as cooked egg around 6 months of age may reduce the risk of developing these allergies. And the current recommendation is that do not delay introduction of allergenic complementary foods into the infant's diet as long as they are able to tolerate it. So let's look at other interventions, such as breastfeeding and the use of prebiotics, hydrolyzed formulas, and so on. So quickly to just summarize, there is no data suggests that breastfeeding is protective in the prevention of food allergy. However, we are recommending, as you've heard the chairperson say, that breastfeeding is to be encouraged for all its other benefits which are beneficial for the infant. However, there's no good data to suggest it will prevent food allergy. Similarly, there should be no exclusion of allergenic foods during pregnancy or lactation by the mother. And there's again no evidence to suggest that vitamin D supplementation, whether prenatally or postnatally, is going to be beneficial in preventing food allergy. So what about looking at long-chain fatty acids? Okay, and again, what they've shown is that prenatal supplementation does not prevent food allergy. In postnatal supplementation of long-chain fatty acids, polyunsaturated fatty acids, there was one study which suggested that there may be some benefit. However, in a later meta-analysis, it's been shown that there was no benefit in reduction of food allergy, though there may be some reduction in food sensitization to egg. Again, looking at probiotic supplementation, they found that there was no prevention of food allergy, though there may be some effect on reduction of sensitization, particularly to milk. So, and if you look at prebiotics, again, there's insufficient data to show that prebiotics prevent food allergies. The studies that have done looking at the use of prebiotics have shown reduction in eczema, unfortunately not food allergy. What about hydrolyzed formulas? Because we do hear that people have attempted to use hydrolyzed formulas to prevent food allergy, and this is Ball's meta-analysis, which looked at both partially hydrolyzed as well as extensively hydrolyzed formula, and again, really, there was no prevention of food allergy. This is a later meta-analysis looking specifically at partially hydrolyzed 100% whey formula, which did show a reduction in allergic disease, but however was not specific to food allergy. So again, this is another Cochrane database review which found that there was no effect of hydrolyzed formula when you compare it to breastfeeding or the use of cow's milk formula in reducing food allergy, particularly in low-risk infants. So quickly summarize this bit of our findings is that we still recommend breastfeeding, but however, it's not for prevention of food allergy. There should be no exclusion of allergenic foods by the mother during pregnancy or lactation, because this does not help to reduce food allergy. There's limited data for the use of vitamin D or long-chain fatty acids supplementation during pregnancy or postnatally. Again, the use of probiotics during pregnancy and prebiotics in infants have been demonstrated to have an effect in the prevention of eczema, but not food allergy. And again, role of hydrolyzed formulas for food allergy prevention probably needs further evaluation. So I'm just going to touch very briefly on management of food allergy. And basically, when we diagnose a child or an infant to have food allergy, the only management is really elimination of the offending allergen. However, remember that management of food allergy does not stop at diagnosis. So we do want to reintroduce the food to the infant as soon as possible, and that's why re-evaluation with serial re-evaluation with allergy tests is always needed. And we can also consider introducing these foods in a less allergenic form, such as with children with egg and milk allergy, we could consider giving them baked egg or milk products, because it's been found that when you bake egg and milk protein, it does render it less allergenic, and some of these children can actually tolerate it in that form. Similarly, for peanut, boiled peanuts or braised peanuts have found to be better tolerated compared to roasted peanut. Always re-evaluate to make sure that these children are outgrowing their food allergies, so that the foods can be reintroduced back into the child's diet as quickly as possible. And that's where oral food challenges may sometimes be utilized. And in those with persistent or very severe food allergies, then oral immunotherapy may be something that may help these children be able to lead a more normal life without this constant fear of having a severe allergic reaction to their food. Thank you very much for your kind attention.
Thank you, Adjunct Associate Professor Go. That was very insightful and so much information in a very short period of time. Next, we have Miss Vanessa McNamara. She is an accredited practicing dietitian with SNDA and on the executive committee of the Asthma and Allergy Association of Singapore. She has 20 years of clinical experience in both hospital and private practice in Australia, the UK, India, and in Singapore. In her private practice, she works primarily with children, supporting children and their families with allergies, working closely with allergists. Now, for a lot of people that are practicing clinically, you likely have come across patients who have young babies, and they sometimes get really confused because you'll be giving recommendations and they say, but for my previous child, it was different, right? The recommendations have changed so rapidly and so many times over the past 10 to 15 years that it's very confusing for a lot of patients, and I think also for clinicians, just because of the fact that it's very difficult to stay on top of all the latest developments. So today, Vanessa is going to provide some of the latest recommendations on weaning your child or weaning a child at risk with allergies, and so we can better understand the current guidelines. So I'd like to welcome Ms. Vanessa McNamara.
Thank you so much, Shalyn, and thank you to FrieslandCampina Institute and to SNDA for inviting me to speak to you all tonight. So as Professor Go has very eloquently mentioned, evidence is clearly mounting that introducing allergenic foods at the same time as other solid food to infants may protect them from developing a food allergy. So obviously extensive research has been dedicated to this area, which is fantastic. And obviously because allergies are increasing so significantly, I think, you know, it's really worthwhile having that focus on prevention and management as well. So while I'm talking today, I'm going to be referring to the Primary Prevention of Allergy in At-Risk Infants Consensus Statement, which was released in Singapore in December 2019, so quite recent really. And actually, Professor Go was a member of the working group for the development of this consensus statement. So this is really relevant to the Singapore and Asia population, but I'll also be referring to the ASCIA guidelines from Australia and the Versace guidelines from the UK, because all of these are really, really new in this area. So I will be reiterating quite a bit about what Professor Go has talked about as far as the what has helped to change the guidelines in this area, just to kind of remind you of why it's happened. But I guess it's really interesting to note that around 10% of Australian infants aged between 11 to 15 months are now allergic to peanut and eggs alone. So that's a really huge number of infants. Now, Asia is a slightly different story, and the prevalence in Asia is as low as around 1% in Thailand of this age group, and up to around 6% in Korea. So it's quite varying around, you know, around the continent. I think what peanut allergy seems to predominate in children less than 5 years of age in Western countries such as the UK, US, Australia. But interestingly, it's quite uncommon actually in Asia, apart from Japan. Wheat is becoming one of the most common food allergens in childhood, followed by egg and milk. That's in Asia, in Thailand, Japan, Korea, and Singapore as well. So whilst a lot of this research has been focusing on peanut and egg, I think we do know that the incidence of these allergies is really increasing in Asia as well. So it's definitely worth considering and implementing our own guidelines in this part of the world. So today, sorry, 1 second, there we go. So today I'm just going to be, again, highlighting some of the historical guidelines and how they've changed based on some of the most recent research. Also, who is at risk, which Professor Go has also touched on, but then mostly when, what and how to introduce allergens, and I guess what our role as health professionals are in helping our patients through this difficult journey. So, I mean, it's really interesting to see how quickly these guidelines have changed, and it's no wonder that both parents and health professionals have been confused along the way. So back in 2000, which was actually when I graduated as a dietitian, the advice we were giving back then was very different. And again, just a reminder of what Professor Go discussed was that, you know, mums were told to eliminate peanuts and tree nuts, and even suggested to eliminate eggs, cow's milk, fish, and other allergens while they were breastfeeding. And that dairy should be delayed until 1, eggs until 2, and then peanuts, nuts and fish until 3 years of age, which is very, very different. And this was obviously based on expert opinion and probably resulted in at least in part, to an increase in peanut allergy over the last 20 years. So in 2008, this was partially reversed because there was a lack of evidence either way. but that just really seemed to confuse everybody even more. So thankfully in 2015, the LEAP trial results were published, and this changed everybody's approach. Now, I'm not going to go into this in very much detail because I know that Professor Go explained the reason why this trial was started based on the fact that Israeli children in Israel had a much lower incidence of peanut allergy than Jewish children living in the United Kingdom. But there were a lot of children involved in this trial, looking at children with severe eczema and or an egg allergy. Now, I think, and then they were followed up at 5 years of age or 60 months, and an oral food challenge was conducted to determine the prevalence of peanut allergy. So for those who did have negative skin prick tests for peanuts, you can see that those who'd been avoiding peanuts developed had a food allergy at the age of 5, and around 13.7% of those, whereas those who'd been consuming peanuts all along had a much, a really significantly less amount. So these infants had been consuming 2 grams of peanuts 3 times a week. So 2 grams of peanut is around 2 teaspoons of peanut butter, or about 2.5 teaspoons of ground peanuts, or around 10 whole peanuts. Obviously, they were not consuming whole peanuts in infants. And so this was really the first trial to demonstrate that early introduction is beneficial. But interestingly as well, even those who had an existing allergy based on the skin prick test, their prevalence was at 5 years of age was far, far more in those who'd been avoiding peanuts. So just to touch on the LEAP On study was an extension of the LEAP study, and it was really just to check the persistence of oral tolerance. So what they did was they followed up the children who had finished and had stopped consuming peanuts for a year after the LEAP study finished. They wanted to find out, did that persist? Did that the low incidence of peanut allergy persists after that time? And what they found after a year of avoiding peanuts, actually, there was still a lot lower incidence of food allergy amongst those who'd been allergic. So I think this study really offers reassurance that eating peanut-containing foods as part of a normal diet, with occasional periods of time without the peanut, is actually, or can be safe practice for most children. So I think that was a little bit reassuring as a follow-on study from that. And then, as Professor Go also went through in more detail than I will, is the EAT study, which was another defining study that defined the change in guidelines for introducing solids. But this was a focus on multiple allergenic foods as opposed to just peanut. And it was starting a lot earlier at around 3 months of age. And really, they just wanted to test. And again, quite a big study with 1,303 participants who were randomly assigned to either the standard introduction, so around 6 months, or early introduction. And that was looking at introducing egg, milk, wheat, sesame, fish, and peanut. So there were really large amounts that these babies had to be fed. So, quite early on in their feeding journey, they were instructed to feed them around 3 teaspoons of smooth peanut butter, 1 small egg, 2 portions of cow's milk yogurt, 3 teaspoons of sesame paste, 25 grams of fish, and 2 wheat-based cereal biscuits every week. And so understandably, less than half of the participants in this early introduction group actually adhered to the trial protocol because it was quite challenging. But I think it was very effective in certain groups of infants, just showing that, the approach is effective if the parents and the infants are able to adhere to the protocol. And the early introduction of all 6 allergenic foods was not easily achieved, but it was safe. And I think that's really what everybody wanted to see. So that really did help to change those guidelines. So for all infants, and this is really just reminding you, as I'm sure you're all aware of these, so this is not the high-risk infants, but for all infants, we're suggesting that there is exclusive breastfeeding for around the first 6 months of life. from around 6 months, and notice the fact that we're really focusing on that word around because it needs to be really individual to the child. But not before 4 months, then complementary foods can be introduced alongside breastfeeding. And we are still suggesting that first foods should include things like pureed vegetables, pureed fruit, some starchy foods, and protein sources as well. A big focus is that foods containing iron are introduced definitely at the 6-month mark, just because infants' requirements of iron drop significantly at this stage. So as we've said, and as you should know by now, excluding egg and peanut from your baby's diet may increase their risk of food allergy. So it's recommended that for all babies, whether they're at risk or not, all common allergy-causing foods be introduced by 12 months in an age-appropriate form. Now, we're not giving specific guidance on texture, but it needs to be appropriate to the child and to their age as well. And then one thing is that once the allergens are introduced, it's important to mention to your patients that they don't just introduce it once, because what we do know is that often the reaction can be more severe or more pronounced, or it first appears on the second or third introduction. So it's important to be giving these allergens on a regular basis as much as possible. So what are the potential allergens that we're looking at? I guess what we need to be aware of is that any food can cause an allergy or an allergic reaction. And this can occur later on in life as well. It's not just as an infant that this will happen. But I guess the allergens that we have here are the ones that are most often likely to cause a food allergy and resulting anaphylaxis, which is obviously what we want to avoid. So egg and peanut, of course, milk, so cow's milk and soy, wheat, shellfish and ordinary fish, and then tree nuts and sesame and other seeds as well are all the allergens most likely to cause a problem. So as health professionals, it's really our job to explain to our patients what potential food allergens may be and the symptoms and signs of a reaction, and to know what to do in the event of a reaction to these foods as well. So we know that there are going to be more of the immediate type food allergy reaction, which is the one that's going to be likely to result in anaphylaxis. So the mild, and these tend to happen within about 30 minutes of consuming the food. So mild to moderate symptoms, although they don't seem mild at the time, are more like swollen lips or face or eyes, some hives or itchy skin, and then perhaps even some abdominal pain and vomiting as a result. More severe symptoms are when breathing is impacted, or when there's a persistent cough that won't go away, or a change in voice, or a swollen tongue, or even a drop in blood pressure, or a child becoming quite pale or unresponsive. So obviously this needs immediate reaction and response and treatment as well in a hospital. The more delayed type, I'm not going to really talk about, but it can happen hours after the food has been consumed, and this can be gut symptoms. It could be a worsening of reflux, or it could be just real discomfort by the child. It could be loose or more frequent stools or infrequent stools, or it can be just worsening eczema as well, and this is where it can be difficult because it can be gradually worsening over a series of hours, over a period of hours. So generally these don't cause any anaphylaxis. Now, again, as Professor Goes mentioned, there are infants who are more at risk, and really those who are at high risk are those with severe eczema and or a food allergy, particularly to egg. Also, those who have mild or moderate eczema are at risk, but not as high as those with more of a severe eczema that needs treatment. And as you can see from this paper published in 2018, that there really is a huge a connection with infants with moderate to severe eczema and or eczema that began in the first 3 months of life. So again, as a health professional, that's something that we really need to ask, is when eczema first began. And definitely for infants who had eczema in the first 3 months, they're going to be at a much greater risk of reacting to both egg and peanut once they're introduced into the diet. So we would recommend, so if they are at higher risk, we are recommending that the child may benefit from starting egg or peanut earlier alongside other solid foods. I'm going to be talking about how to do this in a minute. Those who are not at higher risk, generally, and even if someone in the household has a food allergy, they're generally not at a higher risk. So that can be introduced as normal at around 6 months, those potential allergens. But for those babies who are at a higher risk, it is worthwhile speaking to an allergist or a pediatrician specializing in allergy. Now, this was taken from the Versace infant feeding guidelines for allergy prevention. And, you know, the majority of infants are going to be at a lower risk with no eczema or no food allergy. And these allergens can be introduced quite freely at home. And it's definitely a question that we often get is, how can I introduce these allergens without, you know, going into panic stations? For those who have mild to moderate eczema, obviously, you know, the numbers are relatively high, around 12% of infants. Probably they could be introduced at home at around 6 months. It's good to speak to a health professional about this. But what we're suggesting to those with severe eczema and or an egg allergy is potentially to be testing for this in a clinical situation, so either in a clinic or even in hospital, depending. But so this is where we're recommending that infants at high risk speak to their allergist as early on as possible, not waiting until 4 months. Because one of the issues is if you're waiting too late, then you may be potentially delaying the introduction too late. And ideally, we want to get them to be getting onto this, you know, as soon as possible. So, you know, if so an allergist would look at the IgE levels and skin prick test results, and they would need to be, you know, well versed in this area to decide how the potential allergen is introduced. So I do work with allergists in the hospital situation, and so by doing an oral food challenge is when we would be giving gradually increasing amounts of an allergen such as peanut or egg, of the, say, peanut protein every 20 minutes over generally a 2-hour period as per the Practal protocol. And really, if the infant has tolerated the allergen without reaction, it's really important then that the child would need to keep the peanut in their diet for a minimum of 3 times a week, and at a certain level, but generally around 2 grams of peanut protein, which is about 2 teaspoons of peanut butter. So I think what's really important with the guidelines is that around 6 months means when the child is ready, and not before 4 months is also really important. So a sign of readiness that there's good head and neck control. They can sit upright when supported in a chair. They're not flopping around all over the place. They're showing increased interest in food. They tend to open their mouth when they're offered food on a spoon. And also they're showing an increased appetite. So milk is not tending to fill them up as much as it used to. A reason for starting solids early is not that because the parent wants them to sleep through the night, because that's not usually the solution. Also, if they're showing a sign of losing their tongue thrust reflex, so they're not pushing food out as soon as it's in their mouth. So once they're ready, which could be any time from 4 to 6 months, how to introduce peanut. So we recommend obviously never giving whole or coarsely chopped nuts or chunky peanut butter. To use a smooth peanut butter or ground peanuts into a really fine powder, and to mix these with a pureed fruit or vegetables, or yogurt or porridge, or the kind of normal pureed food that they'd be having. And so we suggest mixing around 1 teaspoon of the smooth peanut butter with a tablespoon of warm boiled water or baby's milk, and then gradually introduce it. So starting with around 1/4 of a teaspoon on the first day, up to 1/2 teaspoon, and then a teaspoon by day 3. Now, this obviously needs to be done on its own with no other new foods at the same time. Some guidelines suggest that you can start by just putting a little bit of peanut butter on the inside of the infant's mouth and go from there. But I think the gradual introduction is the main thing to focus on here. As far as egg, it's a very similar introduction, but we suggest to parents to boil an egg until it's hard boiled, so it's cooked all the way through. We need to make sure that there are no runny bits in the egg. And we suggest combining both the yolk and the white along with the puree of choice until smooth, and then offering it in the same gradual process. So around 1/4 teaspoon, 1/2 teaspoon, and then 1 teaspoon. Obviously, doing this and observing reactions very closely. So we suggest doing this in the middle of the day rather than at the evening meal, so that we have time to observe any reaction. So other allergens, we're looking at trying to introduce all of these before the age of 12 months, but basically the earlier the better. So tree nuts are the same as peanuts, always finely ground or as a nut butter mixed with a liquid of some sort. Cow's milk can be in the form of, say, a Greek yogurt or just a bit of fresh cow's milk added to the purees. Wheat can be given in the form of something like Wheat Bix that can be soaked with their milk or with water, or even, depending on their age, some well-cooked pasta shapes or couscous, which gives it a little bit of texture, or some toast fingers. The same with fish or seafood. It can be pureed or flaked or mashed and mixed in with a fruit or vegetable. For sesame seeds, when we do oral food challenges for sesame, we usually use tahini, which is a sesame seed paste. And we mix that in with a puree. Generally, because it's a little bit bitter, we'd mix that with a sweet puree, like a fruit puree, to disguise the taste a little bit. Or some crushed seeds are fine as well. And then for soy, I like to use something like silken tofu. It doesn't need to be cooked. It's very soft and it can easily be mixed with a puree of some sort, or just add a little bit of fortified soy milk to the puree, as you would with cow's milk or formula. So a few points to consider when you're educating your patients. I think a really important one is that we need to make sure that the baby's eczema is under control before solids are started. So if it's having a flare up, we want to try and treat that first. Otherwise, we won't really know whether there is a big impact on their skin straight away. It's important, as I mentioned, to get support and guidance from an allergist and a dietitian if possible, if resources are available for that. As early as possible, don't wait till 4 months for that. Introduce one new food at a time and gradually increase this over a period of a few days. If there is a reaction, obviously stop that food, wait till the skin or any of the reaction has settled down before starting trying another food. And then once that allergen is in a baby's diet, continue to offer it a minimum of 2 times a week. One thing is never smear the food onto the baby's skin, as it's not going to help to identify an allergy. It's very tempting to think, oh, if I put it on their skin and see if it reacts, then I'll know. But actually, it's really not an accurate way of us knowing whether there's been a reaction or not. Now, some people delay introducing allergens because there's another family member in the household with an allergy to that food. So I just suggest giving the food to when the allergic person is not around to begin with, trying to give it to the infant in a high chair so that they're not likely to be moving around, and then obviously use warm soapy water to wash the parents and the baby's hands thoroughly afterwards, just to reduce that risk of cross-contamination. And so then I see, and I'm almost finished so that we will have some time for questions, but I see my role as a dietitian, but just our role in general as health professionals is to help the parents to make an informed decision, provide them with the facts to help them decide when they are ready to introduce solids, and to understand the risk of the reaction and what that reaction may be, but also to work out whether, it's worth risking a reaction or whether they're going to risk having a delayed introduction. And it's really important to have those open and honest conversations with parents early on, and then to provide them with resources and to know where to go for support and testing if required. So if they require IgE tests or skin prick tests to help direct them. So these are some of the guidelines that I've used for my talk tonight. So I think they're a great resource, and it'll be interesting to see how these guidelines change over the next 20 years. So thank you for your time.
Thank you for that lovely presentation. Again, so much information tonight. Trying to digest it all is just a lot, I think, for all of us. Now we have a fair number of questions, and we have just short of 10 minutes to finish off on questions. So let's see, I think we have a fair number for, starting with Dr. Go. Let me see. First one is, since the food allergy can be influenced by genetic factors, then can we cure it by genetic therapy?
Well, we do know that allergic diseases do run in families, but we haven't really identified a specific gene with relation to food allergies. So unfortunately, I don't think that's currently any suggestion that we could do that.
Great. I think this next one, Vanessa, you actually spoke about. It says to be protective, is it relevant in what form the peanuts were given to the children? Complete product smashed or as peanut butter?
Yes, it could be either smooth peanut butter or a fine peanut powder. But also a lot of the research done in the infants in Israel, they usually use these peanut puffs called bamba, and they're given to infants quite early on, around 7 months. So they can also be that source of peanut as well. And
then does it matter as the kids get older, or any type is?
It doesn't matter. It's just that the dose may increase as they get older, but any form really, in the form of peanut powder, peanut butter. After the age of 5, it can be whole peanuts if they like those, yes, or the peanut puffs.
Great, thank you.
Actually, in Asia, you can also consider giving a boiled or braised peanut because that's really, once it's boiled or braised, it becomes really soft. So it can be given to infants or young children as well.
Okay. I think there was another question somewhere about braised peanuts as well, but it's down the list. So we'll just keep going down the list. How do we interpret the allergy tests? Some children have so many allergens that are strong after the allergy panel. Should they avoid all the foods?
So a positive, and I assume you're talking about a skin prick test, and similarly for an IgE, you can get a positive result, but it does not necessarily mean that the child is allergic. All right, so it just means that the child is sensitized to that particular food allergen, and which is why it's very important to really work up to see whether the child truly is allergic. So what we do in some of these cases, besides the skin prick test, we will measure the specific IgE to that particular food, and all foods have got different cutoffs, unfortunately. So when you do find that a child is sensitized, it's probably good to refer to the allergist so that we can work up the child properly. We sometimes do food challenges to make sure that the child is or is not allergic, because if they are not allergic, then we actually get the parents to give the food. And that's what happened with the LEAP study. So you'll find that there were children or infants who had a positive skin prick test as well as a positive IgE, and yet they were really not allergic. They were sensitized, and therefore they could continue to consume peanut, and that is protective for them. So if you do have a positive result, it probably will be good to send on to an allergist so that they can get proper advice as to what to do with that test result.
Great, thank you. The next question is there a link between prevention food allergy and darm flora of children? I don't know what that is. And do we see differences between natural birth and cesarean section children?
Sorry, Shalyn, you may have to repeat that question again.
Okay. So is there a
Couldn't quite
link
hear you.
between, is there a link between prevention of food allergy, and it says darm flora of children?
I think maybe gut microflora. It might be referring to the gut microflora there. Yeah.
That's the first part of the question. And then the second part is there a difference between natural birth and cesarean sections?
Okay, so when you're talking about natural birth and cesarean sections, it does, what we do know in the literature, it does affect the child's microbiome, and that potentially may affect their risk of development of allergies, whether it may not be specific to food allergy, but actually allergic diseases. Okay, so we don't really know what is, and we do know obviously if you breastfeed, you may be able to mitigate some of these differences in the microbiome. So therefore, even if you're delivered by cesarean section, then probably even more so, the mother should probably breastfeed the child rather than be given formula. But if they are being given formula, then the recommendation that maybe supplementation with a pre and a probiotic may be useful in some of these infants to kind of restore the dysfunctioned microbiome.
Great, thank you. Can young children, I think it's outgrow food allergies by reintroduction management?
Can you repeat that question again? Sorry, I didn't quite catch.
I think the question is, can young children outgrow a food allergy by reintroduction of... Yeah, go ahead.
Okay, so if the question is, can a young child outgrow their food allergy, it really depends very much too on the type of food that the child is allergic to. So we definitely know that children with egg and milk allergy have a very high chance of outgrowing that food allergy. The time of outgrowing or becoming tolerant can vary very much from child to child, but most of the children will probably outgrow their milk and egg allergy by the age of 5 years. Okay, but it doesn't hold true for all food allergies. Definitely, we do know that if a child has a peanut allergy, it may take them longer to outgrow, and fewer of these children outgrow their nut allergy. So whether it's peanut or tree nut, most of them may have persistence of their nut allergy, though it's not as we used to think that once you have a nut allergy, you're going to have it for life. There is still some hope that some of them do outgrow it, though they take a much longer to outgrow. Similarly, for wheat and soy, many of them do outgrow their allergies, but it may take time.
Okay, great. And we are running out of time. Just a couple questions for you, Vanessa. One is it is hard to tell if a baby just showed food refusal without other discomfort. May I ask if there's a specific skill that can be shared in practice?
Yes, I mean, children are going to be fussy, and not all infants like food when they're first introduced to it. So yeah, it's an interesting one. I wouldn't really use food refusal as a guide that they're reacting to it. I would just continue. I mean, you have to realize that it's a very, very new experience for an infant. So unless there's a physical reaction, I would continue to offer the food, and also just make sure that the child is ready. Sometimes the refusal is just a sign that they're just not ready, and they're not really showing that much interest.
Okay, wonderful. And then if you introduce an allergenic food and you see a mild reaction in, it says the largest portion, what is the advice for parents? So I'm
in large portions.
I think so. I think that's what.
I mean, yes, I guess that's when, if there was a reaction at some stage and it's clear that it's that specific allergen that caused the reaction. So this is what I said, is sometimes the first exposure they don't react. It may be the second or third exposure. So it could just be that delayed response. Or it may be that if the food is given in a different form. So, for example, baked egg is more tolerated, in the form of a muffin or a pancake or something like that than, say, cooked egg. So that may be the case. But if there's any concern that there's any kind of reaction to an allergen, I definitely go straight to your GP, and depending on the response, if it's quite severe, then obviously going straight to hospital. But yeah, I would definitely seek guidance from a health professional as soon as possible.
Perfect. Okay, I think that's about our time. We've run a few minutes over. I'd like to thank everyone for joining us again tonight. I hope you found it as interesting and enlightening as I did. Just a reminder, you will be receiving an email from the FrieslandCampina Institute. And in that email, can you please complete the evaluation form so that we can get some feedback on the event tonight. Also in that form, if you would like to receive an attendance certificate, there is a section that you need to complete in order to receive that certificate. If we didn't get to your questions tonight, because we've run out of time, there is a section you can please put it in the evaluation form, and we'll try to get that answered for you. Okay, so thank you everyone for attending.